After our last speaker, who is Elaine Waxman, we'll have some time for questions for Kaylee and for Elaine. So many of you know Elaine Waxman. She's a senior fellow in the Income and Benefits Policy Center at the Urban Institute. Previously, she had worked at Feeding America. She and the Food and Nutrition Board staff over here, who are really wonderful, have been taking copious notes during the entire workshop. And she is going to identify some of the workshop highlights and also some of the unmet needs that were identified during our day and a half together. Elaine.
So I have, depending on your point of view, the lovely privilege or the unenviable task of doing some synthesis from the last day and a half, which has been incredibly rich. And if you could just join me in thanking once again all of the speakers from this morning and from yesterday. Okay, so I would like to, when I finish walking through some of this, engage in some crowdsourcing. Because both things that Maria and I may not have been able to squeeze out of our brain last night when we were working on some of these slides, things that I might have missed this morning when I was writing in the back. But also, it's not possible for us to have tapped all of the potential veins for research and practice in this period of time. So I would also like to hear what you think we left out. But let's talk about some of the things that we learned about what's being left out over the last couple of days. And one of the first things that struck me right off the bat was that we sometimes have a gap between what researchers think about and look at in terms of what healthy aging might represent and how seniors themselves might define that. And it's very important, I think, to integrate both those perspectives and those measurements. And we just, I think, heard that again from Callie, that it doesn't make any sense to not engage directly with the communities that we're talking about when we look at outcomes or indicators of what we hope to achieve. And I think it's a number of places where we've had some suggestion that we're trying some innovative things, but we clearly have insufficient engagement with seniors to understand all of those really complex influences on their behaviors. And they could help inform how interventions might work better. And, we say it all the time, but it was very clear over these last 2 days that cross-disciplinary collaboration is so critical. And if I could just add, one thing that I personally took away is that in so many of these situations, nutrition is treated as a support service, or, in the language of food, it's kind of like a condiment, on the side. And yet it really is a critical health intervention and needs to be front and center. And that means that different kinds of people need to be working more closely together. I learned a ton about emerging dietary science. And I really appreciated Leslie's comment earlier that one of the things that I think we're going to struggle with is how do we help healthcare professionals and service providers integrate and think about how to use all of this emerging information on the ground. First of all, we need to be willing to challenge some of our assumptions. And I think Gordon challenged us yesterday to think about what we think we know about BMI and how that might play out a little bit differently in older years, and that there's more to understand there. Several speakers have helped us think about whether or not the DRIs in a number of categories are appropriate or adequate for seniors, and in particular for compromised adults. They often are built around healthier adults, and there are a number of categories in terms of protein or vitamin D or B vitamins where we may not, in fact, be hitting the mark. We also need to think about the interactions between nutrients, and sometimes they occasionally work at cross purposes, and clearly also the interactions between nutrients and medications or other health interventions. And then it was very exciting to hear about the evolving research on the microbiome. I think the message here is stay tuned. It may open up a whole new set of insights, but we don't quite know what those are going to be yet. Based on my own background and interest, I was very, very gratified that the planning committee put so much energy and the speakers paid such careful attention to senior food insecurity, which I think, as Craig championed yesterday, is really under-discussed and not fully integrated into healthcare for seniors. And it may explain quite a bit about why seniors who look non-compliant around dietary advice, or who are not taking medications because they can't have the food on hand that they would need to marry with that medication. It would help us understand a lot more about why we're not getting some of the outcomes we would hope for. So I think understanding and acknowledging those links, and particularly around chronic disease management, as Hillary reminded us of this morning, needs to be much more fully discussed. And also, several of you mentioned that we really need some insights over the life course. And this is, in particular, a passionate topic for me because there's relatively little in the longitudinal research world on food insecurity. It's actually kind of shocking. And so we need to understand more maybe about what's happening before people hit 50 and how that's affecting what happens after 50, as well as what seniors may be experiencing. Some seniors will clearly be in more of the episodic mode, but we may also be seeing people who are in persistent and chronic food insecurity, and that could be particularly concerning. We did not have time to do justice to the rich array of national programs, but we, I think, touched on a few things that are worth noting here. Clearly, SNAP is a really central part of our food safety net in this country. And there's been a lot of work to understand how we could engage seniors more fully in that program. And I think what we heard yesterday is we've tried some interesting pilots. Some of them worked well, some not so well. That's still important information. Things like simplifying administrative processes, minimizing the need to actually go out and engage in certification interviews, for example, is important. But there's still a group of seniors out there who could be eligible for higher level benefits that we're not getting to. So I think we're not surprised that folks who might only be eligible for a minimum benefit are less motivated. But clearly there's a group that could really benefit that we're not getting to. And I think then the question that Craig and others left us with is, that minimum benefit right now is about $15 a month. I loved how, I think it was from the National Council on Aging, they talked about, well, that's $15 you can put towards your copay for prescriptions. There are ways to talk about that, but that's also, I think, a barrier to additional participation, and we need to potentially revisit the lower end of those benefit levels. And you've heard a few allusions to ways that SNAP might be used, and frankly, non-SNAP incentives for increasing healthier eating. And there is a large set of grants out right now, including, as it was mentioned earlier, one that Kroger and AARP Foundation are involved in, that I think are very intriguing because they're taking some of those early learnings from farmers markets and bringing them into the retail setting, which frankly is where most people shop. So if we want to have some kind of large-scale impact, we have to figure out how to make those incentives work across communities. And while SNAP can clearly be an important strategy, there are a lot of folks who won't qualify. We know that from the income bands that Craig showed us yesterday in terms of who is food insecure. And it's a full combination of programs, some of which we touched on, some of which we really haven't, that are going to be required to meet the need. And those are also combining approaches that are both public and private. And all of you who are engaged in this sector know that, public versus private is not a very useful distinction. They're deeply enmeshed. And for example, when SNAP benefits leave off, somebody else has to pick up, or some programs are administered by nonprofit providers. So it's really a very integrated sector. I think what's intriguing, though, is the potential emergence of programs that we've not typically associated with nutrition, and that is from the healthcare payer side. And we heard some references on for Medicaid waiver programs, some interest from private insurers. I realized retrospectively that in the planning committee, not that we had room to jam one more thing, but it might have been interesting to invite somebody from the healthcare payment side to talk a little bit about where they see the potential for this. To Callie's point, I think we have to show some proof that it's worth their thinking about, but I think we all believe that it can be. Lots of interesting allusions to care transitions in particular when thinking about healthcare and seniors, and realizing that this is a particularly vulnerable window, but that, and there's a lot of energy, but not necessarily good systematic approaches yet. We heard, I think, a few times that there's inconsistent involvement of RDs in particular in some of those activities. And we also don't fully understand yet what patients we really need to target and perhaps what conditions. So there's been some early attention to, for example, diabetes or hypertension, but other forms of cardiovascular disease. There are lots of other things that are diet sensitive in terms of patient management. Lots of challenges for the health professions on top of everything else they're already managing. Part of this, I think, is what I alluded to before, which is how do we translate this emerging nutrition guidance, which continues to evolve, and that always baffles people a little bit, how you translate that into better patient care practice. And part of that also is, do we have what we need in terms of tools for screening? We know that food insecurity is pretty pervasive among the senior population, particularly those who have vulnerable health conditions, but food insecurity screening in healthcare settings is by no means a common activity. And I think what you heard here today, I think, would convince us that it should be, but that requires training and tools and modification of the electronic health record and lots of other things. And of course, you don't want to screen, whether it's for nutritional risk or food insecurity, unless you have something to do about it, right? And so part of that is also then moving, again, nutrition from a support service to a health intervention, and what does that look like? And I think to Hillary's point earlier, is it available to everyone who needs it? One of the things that we haven't talked about in this 2 days is the fact that we actually have some disturbing trends, particularly in rural areas, for mortality at the age of 50. We're actually losing ground for some populations. And I said 50. So while we think we are living longer, and in general we are, there are some communities where we are losing progress that we had already made. And I think that suggests there are a lot of unmet need and unmet capacity development that needs to happen. Methodological improvements, you know, Callie did a great job. So there's a lot of research questions and challenges. In particular, I think we've heard self-reported data. People like to debate the value of that. I would like to argue that senior input is still very important, but we need to be more creative, I think, about the robustness of our assessments. Again, incorporating risk assessment at lots of key points. And somebody made the point yesterday that maybe you assess people when they come in, but assess them again when they go out, because you might do things really differently. And then I think we also heard yesterday about some examples of really innovative validated assessments, like the life space assessment, that helps us think more creatively about the ways in which other factors in seniors' lives affect their nutrition status, and that, for example, mobility. And so that was very exciting to see that we can evolve tools that help us be more disciplined in acknowledging those other influences. We also, I think, had the privilege of hearing about some really innovative and intriguing projects from around the country in terms of engaging directly with senior communities. The Native Food Sovereignty movement and the ways of really engaging seniors in defining something that's meaningful for them and that may actually make sense in their lives, I thought was very inspiring. And it was also interesting how it was connected to larger issues about economic development and stability in those communities. We heard about the use of promotoras and other community-based outreach. I would be remiss if I didn't tell you that there is a new issue of Health Affairs coming out next week, all about food and health. And one of those will be an article on this diabetes food pantry intervention that Hillary is the PI on. And so we'll finally be able to say what those results are, and they're very encouraging. And again, there are lots of other ways to meet seniors where they are culturally, in place, and in response to their particular challenges. In terms of meeting people where they are, sometimes we want to engage them very actively, and I think Julie suggested that we also want to do some passive work and leverage our tendency as human beings to sort of act like mindless sheep many of the time. We have so many food decisions to make in a given day, particularly I think for low-income people or for people who have a lot of other health considerations. And are there ways to learn from some of the insights around behavioral economics that could help us do a better job and reduce the burden of decision making? And I had actually gone looking not too long ago for examples of this within the senior population and really couldn't find any. And so I think there's a lot to be done there. And then this morning we got to hear, I think, some things that both retail and also other forms of food sector evolution that are encouraging. We heard, I think, that there is actually a lot happening, but it's not marketed or identified as senior specific, and maybe it's up to the rest of us to help bring both energy and attention to what there is going on that can specifically support seniors. I can get how senior-specific marketing in the near term is probably not as attractive, but I think the point was also made as the baby boom group moves through, their dollar, their deep pockets will make that probably shift. I liked hearing about the fact that we need to get out of our American exceptionalism and pay attention to what's going on globally, that there's technology, there is product development outside of the US, and that there's interesting regulatory frameworks, for example, that was mentioned from Japan, that we might learn from. So we always think we're the leaders, and we need to back off of that a little bit. That's what I took. And finally, I think this idea of health and food being increasingly integrated in grocery stores, where those two things are meeting in terms of clinics and pharmacies and shopping, in terms of health screenings at food pantries or in the community markets that you heard about, that's intriguing. And I think that speaks right back to meeting seniors where they are and moving away from treating them as if these are separate needs, separate influences, and that they have the time and energy to visit all of our little individual silos that we like to put our work in. So I think that's really exciting and a way to build on. So I will stop there in terms of what I was able to cram down in the back of the corner. But I would love to open it up for you to both nominate other things that you heard that you're walking away from here saying, I'm going to do something a little different because of that, or wow, that's a question we need to know more about. And also, again, as I mentioned, to think about what we didn't get to that we really need to know more about.